Megamind.
Okay, good afternoon, ladies and gentlemen. First of all, I would like to thank Dr. Park, MIGen Korea, the MINEC, as well as MIGen Malaysia for making this opportunity for me to be here in the center stage to share with you all the case that I performed in my university, University of Malaya, Kuala Lumpur. Just briefly explain about myself. I'm Dr. Eshamsul Sulaiman. Currently, I'm the Associate Professor and Consultant Prosthodontist at the Department of Restorative Dentistry, as well as the Head of Implantology Unit at University of Faculty of Dentistry, University of Malaya, Kuala Lumpur, Malaysia. If you do come across to Malaysia, please, you're welcome to visit me at our university. Okay, today I would like to share a case of immediate implant placement in maxillary anterior socket with facial wall dehiscence. So this is about the patient's history. The patients at the time of the presentation, age 24 years old, male patients. In fact, he was also my dental student. He was initially managed by our endodontic colleagues. He actually was referred to me due to non-responsive endodontic treatment. So basically, at the time of the presentation, he complained of discomfort and sinus swelling at the labial mucosa between tooth 1, 2, and 1, 1. Historically, he reported spot injury that happened few years prior to the presentation, involving both tooth 1, 2, and 1, 1. Tooth 1, 2 had been intruded, intrusion injury, together with some enamel and dentin fracture. The tooth was surgically repositioned and splintered, and then the fracture was resolved with composite resin. Unfortunately, a few months prior to the presentation, the patients start to develop discomfort and attended our endodontic clinic, and the tooth was, root canal treatment was initiated by our resident endodontist. Unfortunately, during the course of the endodontic treatment, the tooth failed to heal. Patients still having some continuous pain and discomfort. And following that, the CBCT was taken, which confirmed the presence of inflammatory external root resorptions. Because of the poor prognosis, the tooth was then referred to me for further management as the patient requested for implant replacement. So the photo here shows the presentations, the clinical photograph at the time of the presentation, which you can clearly see the sinus discharge present at the labial mucosa between tooth 1, 2, and 1, 1. The patients also presented with thin gingival biotype, with a scalloped mucosa. And in addition to that, there's also a localized deep pocketing, approximately 7 millimeter, suggesting labial wall defect or dehiscence. So here, you can see the CBCT was taken a couple of months during the endodontic treatment, and the photograph on my right showing the periapical radiograph. You can see the presence of inflammatory root resorption, as well as the interproximal height of the bone, looking at intraoral periapical radiograph. So here shows it's very good interproximal height of the bone. Why is it important? Because if I were to raise the flap involving the papilla, according to Tanau and Salama, I'm quite confident to be able to regain back the papilla field, according to Salama, if the distance of interproximal height of the bone from the crest to the future contact point approximately less than 5 millimeters, the chances of having back the papilla is almost 100% or 98%. And also from the sagittal view of the CBCT, so the tooth 1, 2 is classified as class 1, SRP, sagittal root position, according to Kant et al., meaning that there would be the root in relations to the socket wall housing in very close proximity towards the labial wall, leaving adequate amount of bone palatally which is maybe suitable for the immediate implant placement. And you can also see on the sagittal view on my right again with the 2 implants here, showing that the possibility of placing the implant in relations to the trajectory of the alveolar ridge. So meaning that you can either go for screw retain or cement retain. Unfortunately, in this case, if I were to go for screw retain, which I always, my preferred options for the final restorations, it means that I need to tilt the implant towards the palatal, meaning that the apical part of the implant will be quite close to the labial bones. So because of that, of the defects already present on the labial wall of the socket, I decided to go to the maximum amount of bone palatally in order to get a good primary stability. So because of that, my final restoration would be cement retained prosthesis. So the objective of the treatment is basically to restore both the function and aesthetic for these patients, as the patient is still very young, 24 years old. And the second objective is to restore the long-term longevity of the implant restorations, as well as the peri-implant tissue. So the options were discussed with the patients involving, number 1, immediate implant placement, with or without provisionalizations, depending on the primary stability obtained at the time of the implant placement. Option number 2 is the early implant placement, 4 to 8 weeks. The third one, delayed implant placement, 3 to 4 months. And the fourth would be standard placement in the heel ridge, usually more than 4 months after the extraction of the tooth. And the last option would be alveolar ridge augmentation at the time of the extraction, followed by delayed implant placement. Now, after discussing with the patient with pros and cons of each of the options, we both agreed to go for the immediate implant placement with simultaneous guided bone regenerations. So here you can see that at the time of the surgery, which was performed in November 2017, so today would be, this year would be the 5th year, the case following the implant placement. So the tooth was carefully extracted atraumatically. So you can see on the surface of the root the evidence of the external root resorptions. So because of the presence of the buccal, or the labial dehiscence, I decided to raise the flap. 2 vertical raving incision was performed, one mesial to 1-1, and the second vertical raving incision was performed distal to the canine. And full mucoperiosteum flap was raised to allow me to have a good visibility and also access with the granulation tissue. So you can see here, it's quite a huge granulation tissue present within the socket. So following thorough debridement and curettage of the socket, you can see quite thin labial wall present. The remaining labial wall is quite thin. So the implant will then placed, but prior to the implant placement, in fact, prior to the surgery, I planned this case for the guided implant placement using a software. At the time, it was 2017, I did not have access for the R2 gate yet, so therefore the computer-assisted implant planning was performed using Blue Sky Bio. So it's not fully guided implant placement. It's called it partially guided because the hole here only allows me to place up to 2 millimeters of the pilot drill. Nevertheless, the position following the first initial drill was quite good. MegaGen annual-rich implant, 3.5 diameter, and the length of 11.5 millimeter were placed according to the plan, with insertion torque value of approximately 25 Newton centimeter. Although it's not good for immediate temporizations, but it's good enough for me to place a healing abutment. So here are the preparations of for the guided bone regenerations. So venous blood was taken from the patients and centrifuge using Medifuge machine in order to obtain CGF or concentrated growth factors. So 2 sheets of the CGF were then cut into small pieces and mixed with the allograft from the bottle. And another 2 sheets I would use later on at the end of the procedures. So here you can see the defect from the occlusal view. After placing the implant, you can see the jumping space is definitely more than 2 millimeters. You have a little bit of envelope of the bone here. Purposely, I leave it. Some people may remove it. I like to leave it there because it can support my collagen membrane later. So in the second slide in the middle, you can see the bone graft being packed, the mixture of allograft and CGF being packed inside the defect area over the implant surfaces, and little bit overbulk the augmentations, followed by the placement of collagen membrane. Here you can see the bone graft has been packed all the way to almost level with my healing abutment. This is 4 by, I think, about 5 millimeters, 4 by 4 healing abutment. So I fill it up, the bone graft right to the top, following the concept of dual zone grafting technique by Chu et al. So you can see here, my collagen is only on the buccal side. I did not extend my collagen over the top of the healing abutment, but instead I used 2 sheets of CGF membrane in order to cover the coronal part and also extending towards the labial aspect to protect the collagen membranes. So you can see 50 sutures being used. I also secured the membrane using modified horizontal matrix. So in this slide, you can see prior to discharging the patient, because of the occlusion is quite acceptable. So I then used the extracted tooth, this extracted tooth here, decoronated and modified the tooth, the crown, to form a pontic, which I then link to the adjacent teeth using fiber reinforced composite. So you can see here, it's been placed immediately after the implant placement, and the healing at 2 weeks was fantastic. You can see complete healing of the sinus, although you can see almost visible the 50 thread, meaning that the soft tissue biotype is extremely thin. Okay, so patient was wearing this temporary bridge approximately 5 months. So here, the pictures on the far right, you can of you the healing approximately at 5 months after the implant placement. So at 5 months, we then changed from the temporary bridge to the implant supported or implant supported crown or screw retained implant crown. Yeah, you can see here, sorry, oops. The temporary abutment, I normally use titanium temporary abutment, although I know MegaGen, they have a fused abutment, but in this case, 5 months, I'm very confident of the osseointegration, so I use a titanium temporary abutment. And again, I use the pontic from the extracted 1-2 and modify it to form screw retained implant, temporary implant crown. So you can see here, Yep. And 3 months after the insertions of the temporary implant crown, I took the CBCT. You can see very, very clearly here the amount of bone that presents on the labial aspects, which means it's quite stable, yeah, for the last 5 months. Following that, I then take the working impressions. So normally I would use the open tray technique, but for this case, I use the closed tray technique. You can see here, there's a, MIGen AnyReach closed tray impression coping. But prior to impression taking, you can see the amount of space that's available around the coping because the emergence profile had been created by my temporary implant crown in order to mimic or to copy the emergence profile of the temporary implant crown. I then modified the impression coping. You can see here on the far right here. So it's very essential because by the time you prepare the tray, the tissue might have collapsed if you don't support it. So this technique, modifications of impression coping using flowable composite, would ensure that the emergence profile remains supported. So it is the time of delivery of the final prosthesis. I opted for zirconia, CAD-CAM zirconia abutment, as well as porcelain fused to zirconia crown. So in this case, you can see because of the positions, as we planned right from the beginning, so it's not going to be screw retained, it was cement retained. By having customized abutment, either zirconia or titanium, you can ensure that the margin is very close to free gingival margins of the peri-implant tissue, which allows easier removal of or the management of the excess cement. So in these slides, you can see the review at 1 year and 1 year and 5 months after the delivery of the final prosthesis, which you can see extremely, in my opinion, a good peri-implant tissue. The papilla completely filled both embrasures, proximal embrasures, and the patient is extremely happy. So even though the smile line is very, very low, but by having papilla fill in the embrasures, yeah, definitely will make the patients happy. So let's have a look at the CBCT comparisons prior to the extractions, as well as at the time of the temporizations and the final delivery. So you can see at the time, or a few months after the implant placement, the CBCT shows extremely thick amount of bones being formed on the labial aspects. And at 2.5 years after the implant placement, or 1.5 years after loading, yeah, the bone still remained stable. So here, I just show you the measurement that I did following the CBCT taken 2.5 years after the implant placement. You can see that the value definitely is more than 2 millimeters. Yeah, in this case, about 3.2 millimeters. So today, this year, so would be the 5th year review. So I'm looking forward to see the patients very, very soon, and hopefully I can take another CBCT and can share the case with you all. So I also had the opportunity to perform the aesthetic score, in this case a pink aesthetic score, based on the work by Verhauser in 2005. So just to compare, although the paper said you compare to the contralateral sides of the situations, but in this case I compared with the pre-extractions of the tooth. You can see here is more, you can see here in terms of mesial and distal papilla, completely filled compared to the pre-operative, and 2.5 years after the implant placement. The papilla on both sides of the embrasure is completely filled. The mid-facial gingival level, again, not much different, I would say. Maybe the soft tissue contour is a little bit, I would say, fairly natural, not completely natural. Maybe if you want to make it completely natural, I would perform connective tissue graft to have a bit more cuffing. But without connective tissue graft, in this case, you can also already see a little bit of cuffing at the free gingival margin on the labial side. So the rest alveolar process, soft tissue contour, and soft tissue texture, to me, remains no different. So that's give the overall score, the pink aesthetics, approximately 13, which to me is extremely good already. So the final slide before I conclude, basically what I can say based on the case, or in this case, that review at 2.5 years after the immediate implant placement with simultaneous guided bone regenerations showed a good papilla height or papilla fill, healthy peri-implant tissue, and excellent labial bone thickness, and immediate implant placement in type 2. This is type 2, yeah, with a facial wall dehiscence, where the gingival margin remains the same prior to the extractions. Is, to me, quite predictable, yeah, provided there is adequate interproximal bone height, yeah, to preserve the papilla, as well as adequate amounts of bone palatally to provide primary stability, which is the requirement, yeah, for immediate implant placement. And finally, in my opinion, the allograft and CGF mixed in combination with collagen and CGF membrane may offer predictable guided bone regeneration outcome and a stable peri-implant tissue. So with that, I would like to thank you for listening and giving me the opportunity to be here at the center stage to share the case.
Megamind.